এটা আসবে না? My voice will be audible, I think. Oh, me.
Good evening to all of you. My fellow moderator, Professor Sudip Chakravarti, the distinguished guests, and we have three very promising and established young urologists from Calcutta. I must congratulate Dr. Reddy's for arranging this. Well, we are having a small symposium as well as case discussion on overactive bladder. As you all know, overactive bladder today plays a very significant role among the urological diseases as well as a significant proportion of patients in our day-to-day practice. I think at least 10 to 15% of urological patients presenting in the OPDs and our practices belong to this category. So we are having three speakers, Dr. Saptarshi, Saptarshi Mukherjee on etiology, presentation and investigations of overactive bladder. The medical management will be taken over by Dr. Atanu Jana, and the surgical management will be dealt with by Dr. Devmallo Bandopadhyay. So I would just request Dr. Sudip Chakraborty to say a few words and then we'll start.
Nothing much to add, nothing much to say. In fact, this overactive bladder is really very important and significant disorder in urology, and many people, they suffer so much. Really, some people are disgusted and it affects their social life, quality life. So naturally, it is an important part, and it is important to diagnose pinpointly what is the exact cause, and by exclusion also sometimes. So all these things I hope will be covered by our speakers. And yeah,
10 minutes.
okay, and let's see.
We'll have 10 minutes speaking time, then 10 minutes for the question from the house, and then we'll go on to the case discussion.
A very good evening. I must say that it's a wonderful initiative on part of Dr. Reddy's and also Bengal Urological Society. And being in front of two great urologists, it really feels humiliating, and I am humbled. So what I would like to say that overactive bladder is a topic that we have discussed not only through our PGT days, but after also entering into the consultancy period. It is perhaps one of the most common diagnoses that we encounter in our OPD visits. So just I'll try to wrap it up from the clinical perspective that overactive bladder is actually a symptom complex, a syndrome with a sudden and unstoppable need to urinate that usually occurs with frequency and nocturia. The most symptom that should mark the diagnosis of OAB being urgency that may or may not be associated with a leak. Coming to incidence, actually OAB is a dynamic condition. So calculation of the particular incidence is often difficult, but the US data, as what I've said, is around 1% per year, and would have been really nice if we could have had the Indian data. Our experts, Sudip sir and sir, could have told us what the actual incidence is, because we have really found quite a lot of patients facing us with OAB. So moreover, another important thing is the progression. That is, a patient presenting with urgency and progressing to an urgency incontinence. This rate is around 1%, 1 to 2% per year, whereas the spontaneous remission rate is around 6% per year. I won't go into the very theoretical details of pathophysiology, but would like to mention few things, because before going into the diagnosis and the management, we need to know the causes of OAB. And for that reason, if we get a reminder of the pathophysiology thing, it would be easier. The neurogenic hypothesis, the myogenic hypothesis, and the urothelium hypothesis. Very easily, as the name suggests, the neurogenic hypothesis relates to any causes that actually disrupts the normal neurocircuitry that controls the micturition reflex, whereas the myogenic causes tells the culprit is actually the detrusor muscle, where there is spontaneous excitation of the smooth muscle cells followed by a propagation to involve a larger part of the bladder. And the urothelium concept shows that there is often a hyperactivation of the urothelium to various sorts of stimuli, be it a chemical stimuli, be it a mechanosensation, be it a pain. And this occurs because a microscopic communication have been actually elucidated between the urothelium and the suburothelium. So now, after going through the pathophysiology, we can quite easily understand the etiology. So if the neurogenic problems are there, think about any neurogenic causes, be it a cerebrovascular accident, be it a spinal cord injury, be it a dementia, be it a multiple sclerosis, it would have an impact on the normal micturition reflex and can result in OAB. Coming to the myogenic hypothesis, if we think about causes that actually have an impact on detrusor muscle, can again give rise to OAB. So be it an UTI, be it a bladder tumor or a bladder stone or even a BPE. So whenever a patient comes into our OPD chambers, there are few people when we should have a red flag sign in our head that these people are at more risk of having OAB. So be it a white ethnic origin people, be it patients with insulin dependent diabetes mellitus, people suffering from depression. This is quite an interesting thing because recently in the 2020 yearbook of urology, an interesting publication came out mentioning that anxiety prone patients have got a very strong relationship with development of OAB. Whether it's a causal relationship, that is still not properly depicted. People aged above 75 years or especially in their 8th decade. Now, coming to the most important clinical part, symptoms. When we should suspect a patient suffering from OAB, what are the common symptoms? So as we all know, the PGTs are over here. The irritative LUTS, voiding LUTS, that's quite a common thing. What are the other things that we should look for in these patients? The clinical assessment, what the history should include. This is a very important thing often being asked in the MCH final exams also, that all the histories about the irritative LUTS and the voiding LUTS are important. And to go with it, keeping in mind the etiologies like a bladder tumor or a bladder stone, definitely ask for the presence of hematuria or dysuria, any evidence of suprapubic pain. Lastly, symptoms are often best explored with a symptom-based questionnaire. Often we are not acquainted with these things, but try to develop that and try to have that at your own disposal. The clinician should also inquire about the fluid intake to assess for any polydipsia and stimulants that could worsen the above urinary tract symptoms like caffeine, smoking, etc. Other symptoms should also be evaluated. Again, the importance of the pathophysiology comes because you need to ask about any new onset tremor or any evidence of erectile dysfunction, because that can actually have a premonitory sign of a neurological disease. Also ask for other existing medical conditions. Perhaps this won't help you in your diagnosis, but this will help you in planning the treatment, especially the pharmacotherapy, like a patient of closed angle glaucoma, a patient who already suffered from AUR, or patients with cognitive impairment. So before prescribing any anti-muscarinics, we should give it a double thought in those patients. Likewise, before prescribing mirabegron or beta-3 agonists, presence of systemic hypertension should be taken with a pinch of salt. Very importantly, the current drugs taken by the patients are very important. Just a few important drugs that should be maintained, because these are quite common drugs taken by these patients. Like a patient not having a proper sleep can be on some sedatives like a benzodiazepines, quite a common drug. So just check those things. A patient coming from being referred from a general physician can already be on alpha blockers. Patients with systemic hypertension being referred from a cardiologist or a general physician can be on diuretics. So all these drugs can have an impact on the symptoms of OAB. To evaluate OAB, the lower urinary tract of the patient is actually reviewed, and the consistency of the symptoms of OAB is also ensured. So as I've already mentioned, the various comorbidities does play a very important role in the diagnosis. So be it a neurologic disease or motility defects, and most importantly, a fecal motility disorders are very important. The bowel symptoms must be inquired in these patients. A history of local symptoms like recurrent UTI, any evidence of gross hematuria. So these are to be inquired with quite precision. Apart from all the history, as I've told, after you have gone back from the history of present illness, the following history of the patient should be known. The onset. Why the onset is important? For example, a postmenopausal female have come to you with suggestive of a urogenital atrophy, often will describe the symptoms with a gradual onset, whereas the same patient with a lower ureteric stone, a VUJ stone, can come with a recent onset urgency. So onset is very important in this patient. Severity. That will actually be helpful to plan your treatment, to whether to start a monotherapy, whether to go for a combination therapy, the duration and the nature of OAB, whether associated with a leak or not. As I've already mentioned, a medical history, be it neurological, cardiological, everything, and a surgical history, especially any form of pelvic surgery, or whether the patient have undergone any previous anti-incontinence surgery, sling surgery, or whether the patient have undergone any previous surgeries for prostate. So those all are very important things. Especially in females, obstetric and gynecologic history, whether the patient had multiple births, can give you an idea about stress incontinence. Patients having any history of PFR, pelvic floor repair, or gynecologic histories, especially prolapse. And social history, smoking, alcohol consumption, they do have a significant impact on the symptoms of OAB. Coming to the examination part, don't ever forget to maintain the abdomen. A patient with an insensible loss complaining of nocturnal enuresis, don't forget to palpate the bladder, because that can often be the sign de quana signifying that that's a paradoxical incontinence. So look for abdominal examination. It can give you more ideas about any scar mark, any pelvic radiation marks. A thorough pelvic examination in case of males, the genitalia. In case of females, especially in elderly females, evidence of urogenital prolapse, any evidence of vulvovaginal atrophy in the form of dryness of the mucosa, urethral caruncles, any vaginal mass. So those are very important. One thing that I should not have mentioned over here that should have been a part of the history is evaluating the frequency of voiding and nocturia, especially getting a frequency volume chart. That is very important. It's better that if you can actually depict by drawing in front of the patient. Bladder diaries is actually an extrapolation of this FVC chart, where the patient will actually also mention the incontinent episodes, if probable, the nature or the amount of leak, if she or he is suffering from. So, without taking much more time, at the conclusion and the take-home message, the overactive bladder syndrome is actually a symptom complex of urinary urgency with or without urge incontinence, usually with frequency and nocturia, and more importantly, it is a sort of a diagnosis of exclusion in absence of UTI or any other demonstrable causes. The prevalence of OAB normally increases with age. Typically in females, it starts to occur in the mid-40s, whereas in the males, it tends to occur a decade or two later. Drug treatment plays a very important role, but more importantly, perhaps we would be discussing in the case discussions, lifestyle modifications like behavioral therapies are almost equally important. And to go with it, counseling. We should not forget that also. So familiarity with this condition and basic knowledge about the diagnosis and treatment options can contribute to the general health. And as we know in today's era of medicine, not only prolonging the life, but the quality of life is equally, if not more important in these patients. Thank you. Thank you, sir.